Hi, good evening, good morning, good afternoon, everybody. It's 7 p.m. in Paris, 7 p.m. in Barcelona, 7 p.m. in Düsseldorf and Aachen, and noon in Rochester. And it is my great pleasure to welcome you to this very special international activity by the International Academy for Clinical Hematology, dedicated today to telemedicine in hematology. Where do we stand? I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And it is really a true honor and privilege to have today with me three distinguished faculty who have kindly accepted to prepare a few slides and contribute to this very unique educational activity because as you are all aware of, since this COVID pandemic, there has been really a breakthrough in terms of the use of telemedicine. And the idea was brought to the ICH, and I'm very thankful to you, Alberto, by Dr. Alberto Mussetti, who is the head of the transplant program at the Institut Català d'Oncologia. This is the Catalan Institute of Oncology in Barcelona, very famous institution in Barcelona. He has an amazing track record of research in the field of allotransplant and immune therapy for lymphoid malignancies. But most recently, he has devoted a lot of time also to the use of telemedicine and how we can bring telemedicine to help our patients. I have also with me today another distinguished faculty, and I'll go by alphabetical order, Dr. Malte Jacobsen from Germany, who is actually a cardiologist, not a hematologist, but we at the IACH are very open-minded and we would like to learn from our colleagues from other fields. And Malte is a cardiologist at the Aachen Hospital, and he has a very special interest actually in the application of wearables for the purpose of remote patient monitoring in cardiologic and oncologic populations. And last but not least, we are also joined by another distinguished faculty, Dr. Jonas Paludo, who is an assistant professor of medicine and oncology at the Mayo Clinic in Rochester, Minnesota. And he is also a very well-known expert in the field of cellular therapy and translational research in lymphoid malignancies, but also implementation of innovation, novel technologies for the management of patients with cancer. So thank you to all three of you for joining us today. And I think, Alberto, you have structured the program today through three short presentations, followed by discussion, a roundtable discussion. So it's an interactive activity. Please don't hesitate to send questions, to post your comments, and I'll do my best to share it with the panelists today. So without any further delay, I'd like to introduce Dr. Alberto Mussetti to his introductory slides, and we'll take it from here.
Thank you, Mohamed, for the opportunity to host this type of a meeting, and welcome everyone. I'm Dr. Mussetti from Barcelona, and in today's talk, I'm going to talk a little bit about what is telemedicine and what is the role of telemedicine in hematology today. So here are my conflict of interest. And in today's talk, we are gonna talk briefly about what is telemedicine, so definition, history of telemedicine, and the types of telemedicine that we have today, And also in the second part of my talk, I'm going to talk about a little bit about the benefits of telemedicine and why we consider that telemedicine is actually a major improvement in medicine and, of course, in hematology. And finally, we will talk about a few examples of the use of telemedicine platforms and studies in hematology in both the pre-COVID era and the post-COVID pandemic era. But then we will conclude this talk because I think that the most important part of this discussion is the data of the study pioneered by my colleagues Malte and Jonas. So first of all, I think that there is not a general definition about what is telemedicine. So what I did was ask, of course, to ChatGPT for what is telemedicine. Please define, give me a definition of telemedicine. And actually, I think that the answer, as always, it was pretty good. In fact, you can see that telemedicine refers to the use of telecommunication and information technologies to provide healthcare services remotely. And that's the most important point and definition, but also it says that it enables healthcare providers to deliver medical care, consultation, diagnosis, and treatment to patients who are not physically present in the same location as the healthcare provider. So apart from this joke of using this tool, the ChatGPT, but actually this definition is very similar also to the definition of the American Telehealth Association, which actually is the biggest non-profit association of the US dealing with telemedicine, where we should categorize and put this telemedicine in our current field of medicine. So maybe telemedicine is part of both the bigger world of the digital health, which consists in the use of digital technologies in order to offer medicine to the patient, and also in the setting of precision medicine. So telemedicine has different categories. I think that maybe this graph was made by our group, so it's a personal interpretation. But in the different subgroups of telemedicine, we can stratify the use of mobile health, which is also called mHealth, which is the use of basically mobile devices to offer healthcare services to the patient. Then there is the remote patient monitoring, which basically consists in the use of wearable devices for the monitoring of patient. And finally, technology-enabled modalities. So telemedicine is strictly related to the development of telecommunication technologies. In fact, maybe we can consider that the telemedicine started with the invention of the telephone and in the second part of the 18th century. And we have some proof of the use of telephone for doctors at the beginning of the 20th century. But it is only from the 50s that telemedicine began to be used also in a systematic way with the invention of two-way audio and video communication system. And this was possibly used during bigger conflicts during the 50s and during the 60s for military services. And finally, in the 90s, with the advent of the internet, it was finally possible to transmit medical data online. And also it allows this data to be interpreted over long distances. And today, of course, our means of communication has improved so much, but also in the future, we will possibly have more powerful tools for communication, and which could be applied to the setting of telemedicine. I'm citing, for example, the use of a virtual visit, the metaverse, who knows, and also the use of drones to deliver a therapy. And what about space medicine? Of course, in space, we want to have a hospital, and telemedicine will be possibly fundamental. So when we talk about telemedicine, we should always keep in mind that there are two sides constituting a telemedicine visit. The origin site, which is the site where the patient is located. The origin site is sending data to the distant site, and the distant site is where the healthcare operator is located. Another very important characteristic of a telemedicine visit is that this type of visits could be synchronous when the data are directly sent and interpreted by the healthcare operator, or asynchronous when the data are sent and a posteriori later will be interpreted by the healthcare operator. And basically, if you keep in mind this definition, we can distinguish three types of telemedicine. So the first one is the store and forward telemedicine, which consists of transmission of medical data and images from one location, origin site, to the distant site for review by healthcare provider. I'm referring especially, for example, radiologist or anatomopathology, or in the setting of hematology, morphologist, of course. And in this case, the type of visit is, of course, asynchronous. Then there's a second type of telemedicine, a real-time telemedicine, which is a live conversing between the patient and the healthcare provider. In this case, I'm referring to the common visit that also us as hematologists are performing in real time with our patient. Could be telephone-based or video telemedicine based. And finally, there is a third category, remote patient monitoring. This could be a mix of both synchronous and asynchronous technologies to remote patients' vital signs. Why we believe that telemedicine is an improvement for our society. Basically, there are three big advantages of this technology. The first one is that telemedicine could increase the access to healthcare, providing healthcare services to patients who live in rural or remote areas. Just think about countries where healthcare hospitals are not equally distributed along all the country. The second point is that telemedicine is a cost-effective system. In fact, it could reduce healthcare costs by reducing need for hospitalization, emergency room visits. And if you think about what happened during the COVID pandemic, maybe this point was the clearest point that we have in our mind when we think about telemedicine. And finally, there is also an improved patient outcomes. In fact, for fields like chronic diseases, cardiology, we'll see Malte that will talk about this later on, or patient with diabetic diseases. A real-time monitoring of such complication actually could improve the outcomes of such patient. And also, of course, there are a different type of technology that we can use for telemedicine. There's the classic video conferences or telephone. And telephone or telemedicine maybe is not the newest telemedicine system, but maybe is what we have used most until today. Remote monitoring devices, the storing of the clinical data on electronic health records, and mobile health apps, which could help our patient also for education, appointment scheduling, and so on. So what happened for patient in hematology during the pre-COVID era, depending on a recent review which has been made in 2021 about this topic, we see that telemedicine has been generally used for diagnosis and follow-up of a patient with chronic hematological diseases. Of the 32 studies that have been identified by the authors of this review, at least 24 were considered of low grade quality. And of course, there was an heterogeneity of the population and the telemedicine platform that have been used. One example from our colleagues from the Memorial Sloan Kettering Cancer Center, which was published back in 2020. In this case, our colleagues used a video conference system which was constituted by a high-quality video device and also a digital stethoscope, which allows for a real-time two-way interaction visit. They included patients who received both autologous and allogeneic stem cell transplantation. And at the end of the study, which was a pilot study, it was asked to both patients and physicians what they think about this technology and this type of visits. If you focus on table 1 of this study, you will see that while for the 27 patients which were enrolled into the study, the final overall satisfaction with the telehealth devices was pretty good, more than 4 in a scale from 1 to 5. while for the clinician performing the visit, it was just 2.6, and this was probably the causes of this low valuation from part of the healthcare providers was that majority of them, they had not that feeling of performing a real visit, that they had not that feeling of having visited the patient well. In another era, the COVID pandemic era, and right now, the use of telemedicine has been used basically to reduce the in-person visit of hematological patient, and thus reducing the risk of infection of this patient. Was generally used for both chronic and acute condition, but also here a higher heterogeneity of studies and type of patient and platforms, and the majority of study are pilot as well. Two examples just to conclude my presentation. In this first report, which was published in the British Journal of Hematology in 2021, from Italy, almost 500 hematological visits were transformed into telemedicine visit for immune thrombocytopenia, essential thrombocytopenia, polycythemia vera, and myelofibrosis. And as you can observe here, the number of telemedicine visits increased during the COVID pandemic up to almost 800% compared to the pre-COVID era. But in this study, there is one important point, I think, which deserves to be discussed here. And it is basically that we cannot transform all the visits of our patient into telemedicine visit. In fact, patient with higher burden of diseases, such as patient affected by myelofibrosis, was generally not transformed into telemedicine visit. Patient under active therapy as well received less telemedicine visit, and of course, patient enrolled into clinical trial. And here you can observe differences between this population. So the first point and most important point of this study is, yes, we can perform telemedicine in case of a pandemic, for example, but not all patients are equal, of course. And another study from our group, this is what we did during the pandemic. We tried to build a telemedicine platform for patients who received both autologous and allogeneic transplantation. In this case, our platform was constituted by a mobile application for the patient who had to insert his vital sign. In this case, the patient had to do this task manually, so it was a self-reported outcome app. And then the data were transmitted to a web-based platform where the physician could look at this data. And the important observation of our study, which of course it enrolled only 21 patients, but still we see that only half of the patients were able to join and complete and take part into this study, and the other half of the patient could not complete or join the study because of the absence of digital education. So they were not digitally educated. But when we look at the results and the compliance of the patient who finally take part into the study, the satisfaction and adherence was very elevated. So here in this table, you see that in a scale from 1 to 5, there is a generally very well appreciated system from part of the patient, but we are talking about only 50% of the patient. So here we're introducing the topic of the absence or presence of the digital education. So in summary, telemedicine is feasible and it could be useful also in the setting of a hematological patient. Until today, the majority of studies are low quality studies in this setting, and we can clearly see what are the barriers to telemedicine today. For example, lack of institutional or government support, low digital education, not just for patients, but also for healthcare providers. And of course, there is still a technology gap. And with this, I conclude my presentation.
Thank you very much, Alberto, for really a very beautiful introduction. And you went back in history more than 100 years ago. So this was really extremely important. As I mentioned, we will have a discussion at the end, so please don't hesitate to continue sending and posting your comments and questions, and we will discuss them. So now I'd like to introduce Dr. Jonas Paludo. So Jonas, the floor is yours.
So thank you, Mohammed, Alberto, and Malte for having and allowing me the opportunity to share a little bit about our experience with outpatient CAR T management, but specifically focusing on how we have been incorporating some telemedicine options in the management of this acute situation or the acute care post CAR T infusion. So here's my conflict of interest. So CAR T, I'm sure most of you are very familiar with CAR T, which is a novel modality of therapy that has really transformed the management of several hematologic malignancies over the last few years. Now, our CAR T is a remarkable new treatment. The unpredictability of the short-term toxicities can be a major challenge, which frequently require prolonged monitoring with even prolonged hospitalizations to monitor for those acute short-term toxicities. At our institution, we have been managing CAR T patients in the outpatient setting for a few years through the use of our hospital-based outpatient CAR T practice, which is integrated and has direct connection with the inpatient service. This is a short schema or a small schema of how the outpatient practice and the inpatient practice for CAR T are integrated. Now, patients, they are seen daily in the outpatient setting for the first 7 days as to comply with the REMS program. Now, those visits are then adjusted based on clinical setting, but the important part here is that those visits can be converted to video visits or video conference televisits, in alternating between the in-person and video visits, so the patient doesn't have to be here every day. The hospital-based outpatient team has direct access to the inpatient service, as I mentioned, and in fact, it's the same group that rotates back and forth, so they know the patients very well, they know the practice as well, and they can kind of easily transition patients. Another important point I want to highlight here is the RPM, or the Remote Patient Monitoring Program, which is a part of our outpatient CAR T management, and is actually a very important part of what we do and how we maintain and monitor these patients in the outpatient setting. Just to show a couple, some data, since the beginning of our outpatient practice in early 2018, we have treated 120 CAR T patients with FDA-approved CAR T products in about 4.5 years window. Interesting that out of those 120 patients, 102, so 85%, were able to receive the CAR T infusion in the outpatient setting. But here's the important part, or the interesting part, that 18% or 18 patients out of those 102 never required a hospitalization during the entire month of monitoring that these patients go through in the post-CAR T setting. Remember that in most other institutions, those are patients that are hospitalized for a week or two, depending on the scenario. Now, moving on to the next part of the telemedicine components, the remote patient monitoring program, which I will spend most of the time today. So remote patient monitoring is it's a novel care delivery model. As Alberto was mentioning, you're using technology or devices at home that is connected or has centralized medical oversight. It's used to facilitate the management at home of conditions or situations that would otherwise require a higher level of care. It has been used a lot in chronic conditions. We have been trying to implement that more in the acute setting, in the transplant or CAR T setting. We developed our CAR T RPM program specifically to detect the early signs of those acute complications post-CAR T, specifically cytokine release syndrome and neurotoxicity. So in our CAR T program, we monitor vital signs and neurologic symptoms using devices that the patient is given to take home. Those devices collect data and integrate with our electronic health records. The data then come in, collected by the patient or the caregiver, uploaded in real time to a dashboard where we have our CAR T nursing team reviewing that. And we have developed a triaging algorithm, or triaging tree, that can categorize those alerts as they come in based on urgency. It can define the next step on the monitoring of that patient. A little bit more of an overview of the program. every patient receiving an FDA-approved CAR-T product in the outpatient setting is eligible for our RPM program. We offer this as part of our care, and I'd say that probably more than 98% of patients enroll and participate in our RPM program. The monitoring period goes from day 0 when they're getting the CAR-T infusion all the way to day plus 30, since that's when we see most of the acute complications post-CAR-T. But the program is put on pause or hold when a patient is hospitalized. So they may be hospitalized for a few days. The program is paused when they are discharged a few days later, and that's resumed. That remote monitoring is resumed. More for a daily overview of how the RPM works in our CAR-T population, we have vital signs and a short questionnaire assessing mental status that's completed 4 times a day around the time periods I'm showing here. Additionally, patients are coming to our hospital-based outpatient unit for a daily visit, not necessarily every day, but that's usually done in the morning. We may be requesting more than just 4 time points of vital signs assessment, depending or based on our triaging algorithm or triaging tree, as the nurses may be requesting some extra vital signs or data points. So here's a simplified version of our triaging algorithm or triaging tree. As those alerts are coming in from the remote devices, they are being categorized into routine, urgency, and emergency criteria, and that would then define the next course of action. It could be just continue with the routine monitoring, nothing different than what has been done. May lead to a phone call from one of our nurses to the patient to get more information about symptoms or new changes, repeating vital signs, all the way to indicating that to the patient to present immediately for an in-person assessment in our CAR-T unit. We started with RPM nurses, CAR-T nurses. Now we have a hybrid model of who monitor those alerts as the first line of defense with our RPM nurses, and then they can escalate that to the CAR-T nurses if that's necessary. Just to share some of the early data on how the program has done, we present initially the data of the 21st patients enrolled in the RPM program. In this program, in the table here on the right, you can see some of the demographics. Most patients had lymphoma. You can see the CAR-T products used here. CRS neurotoxicity rates are here. Nothing outside of the ordinary or the expected for that time period. For those first 20 patients, the monitoring period was 18 days, the median 18 days, shortened to 30. As if you remember, I mentioned that the program is put on hold when patients are hospitalized and resumed upon discharge. There are a median of 231 points per patient during that monitoring period, with a median of 20 alerts and 20 missing data points per patient as well. Now, in the early days, we had some technical issues, and that was causing a lot higher number of alerts and missing data points, which we have improved on that. Now, out of those 20 patients, 13 patients had RPM alerts within 48 hours of the first admission post-CAR-T infusion. 6 patients met the urgency criteria and 7 met the routine criteria. For those first 20 patients, no one had met the urgency criteria. The remaining 7 patients without those alerts, they are hospitalized for the reasons as you can see here, including acute pancreatitis, neutropenic fever. There are some post-infusion reactions and so forth. Now, considering only those 13 patients with alerts, patients that met the urgency criteria, you can see the urgency criteria alerts here in the table. And now those patients were hospitalized at a median of 4.8 days after CAR-T infusion, with a median of roughly 6 hours from the last RPM alert to admission, and median of 12 hours from admission to first tocilizumab for cytokine release syndrome. For those the routine criteria, the median time of admission was almost 3 days post CAR-T, 10 hours from the last RPM alert to CAR-T to admission, and 43 hours from admission to tocilizumab. So when we look at the when we compare to the routine criteria patients, the urgent criteria patients, as categorized by the triaging algorithm, they were hospitalized later in their CAR-T course, with a shorter time from last alert to hospitalization and a short time from hospitalization to tocilizumab. So what does that suggest? That suggests to us that the triaging algorithm was able to categorize those patients that require a more expedite hospitalization or had early initiation of tocilizumab after admission, meaning that we're trying to be able to identify which patients require more urgent treatment versus those that could wait longer before requiring intervention. I won't go into details of this busy figure here. We have presented at the last ASH by Dr. Bansal. We're putting together more information on our first 100 patients that enroll in the RPM program. I can tell you one thing here is that one of the major limitations of our RPM program is that intermittent monitoring of alerts, as there are patients having clinical changes or new changes happening in between those time points. They're hospitalized without having any alerts, we're missing that information. Now, we think that the use of wearable devices can help with that. Now, we have experience using a wearable device for continuous monitoring of temperature in the post-stem cell transplant setting for detection of neutropenic fever. We had enrolled almost 90 patients on that study, and we used that data to develop a model that was able to predict development of fever with a couple hours in advance. And a couple hours is enough to keep patients in the outpatient setting to save that cost of admission, but still maintain the safety in this acute monitoring program or period. So using that experience with the monitoring the transplant setting, with the need for more continuous monitoring and now having more available wearable devices, we developed a clinical trial that's currently open for enrollment, where we use wearable devices for continuous monitoring of vital signs post-CAR T for that entire month post-CAR T. And we also developed a mobile app designed to detect early signs of neurotoxicity or early changes that could be seen with neurotoxicity. And we are enrolling patients, we are collecting that data, and our hope is that we're going to be able to use that data that we're collecting to develop a model that can alert us when a CAR T patient is starting to or is about to start developing CRS, neurotoxicity, or infections that would then require an intervention. So again, we're trying to use that so we can keep these patients in the outpatient setting and keep them outside, or even facilitate the use of complex treatments like CAR T or stem cell transplant, for example, that these patients could be staying in smaller hospitals, not in central or academic institutions, so we can facilitate that access as well. I believe this is the last of my slides. I want to thank you all for your attention, and I'll be happy to take questions at the end. Thank you.
Thank you very much, Jonas, and thank you for sharing this really fantastic experience, actually very significant one, with 100+ patient ambulatory CAR T cells, quite unbelievable. And we have already a lot of questions about this. So now it is my pleasure to introduce our cardiology colleague, Dr. Malte Jacobsen, who will share his own experience and see how we can have some cross-fertilization, I would say, between the different disciplines. So Malte, the floor is yours. So one question while waiting for Malte, Jonas, for you, how far were the patient living, when you run these CAR T cell tele monitoring or remote monitoring?
Yeah, so far they have to stay in town in Rochester far, because we have not got to the point yet. We have proven to be safe to allow them to be further out, but that's the ultimate goal. Okay, we'll come back to this. Now, Malte slides are here.
Thank you very much. So we heard already a little bit about the wearables and maybe some advantages of wearables in the case of oncology treatment. And I would like to emphasize just a few points here. So I think the advantage of wearables here will be that we can gather longitudinal data in a high resolution and in a non-obtrusive way, so that patients that are already in a, let's say, very special situation can transmit data without any further efforts. So while we saw that the oncology population is very good target population for wearable-based remote patient monitoring, I think we heard already a few points of that, that the incidence of clinical and potentially life-threatening complications is very high. And we learned from Jonas that how big the proportion is of patients in undergoing CAR T-cell therapy with complications. So I think, there's really a medical need for a better remote patient monitoring in this population. So we came up with the COMMOD-COST study, which is just an acronym for Continuous Mobile Device Monitoring using a BioVotion wearable, which is was a former Swiss company, which was actually nowadays Bioformus and is now a US company. I think, Jonas, you might know them as well. The wearable was an upper arm wearable, which was CE marked for this purpose, with a battery life of 24 hours and internal data storage capacity of 4 days. And I'll come back to that later, while I'm going here in that much detail. So as you can see on the right-hand side, these are the vital signs which were acquired, and you can see on the bottom the resolution. So we had about almost 90,000 data points per day of the patients we were monitoring. Just briefly, the study design, we had 2 cohorts, the inpatient cohort, so these were all patients undergoing allogeneic or autologous stem cell transplantation, and they were hospitalized for up to 50 days. And we just try to manage a very complete monitoring during their inpatient time. For the outpatient cohort, we had it a little differently. We started with the chemotherapy and then stopped monitoring those patients when the treating physician said that there is no longer a vulnerable phase for any complications. And the cumbersome procedures you see here on the floor or on the ground is 2 wearables per patient, and we had to alternate those wearables due to GDPR regulations. So we were not allowed to transmit any data via web services, so we had to use the internal data capacity of the device and download those data on a stationary Bluetooth. Tended this wearable were pretty long, so we had to do this alternating rhythm to enable really a continuous monitoring with the device. Also, we collected symptom-related POs during those almost every 3 days visits. In total, we had 2 doctoral candidates performing 680 visits to manage the continuous monitoring for those patients. Here you can see the baseline characteristics, especially when it comes to the malignancy. You all probably know more than I do. I think just a very important point here is that besides the hematologic malignancy, we see a pretty young and healthy population, and this is definitely also the point which makes the hematologic population a very good target population for using such digital devices, as they're very familiar. So just to emphasize the point a little more on the complications, just as Jonas did before, during our study, 140, we called them serious clinical complications, so defined by the CTC grade equal 3 or higher, occurred in those patients. So I think this really emphasizes the point why a good and close and monitoring for those patients is really essential. So let's see and look at some data here. We have the adherence data here. So you see on the y-axis the percentage the patients were wearing the wearable, and on the x-axis the days the patients were in the trial. The bars, the blue bars show the inpatient numbers still enrolled in the trial, and the green bars show the outpatients in the bar. And for the plots, it's the same. So you can see we concluded that this adherence is actually pretty good, especially for two reasons. So we had to tell the patient that they were blinded for the wearable data, and we had to tell them that they have no individual benefit from this remote patient monitoring. And still we see in total and in both cohorts around 80% of adherence. And I think this is really good and supports us with our initial assumption that those patients are really open-minded for such a monitoring approach. As you can see at the end of the outpatient cohort, the fluctuation is getting a little higher, but this is just depending on the very low number still included in this trial then at that point in time. And in total, we had about 30,000 hours of wearable data, and I'll come back to that later as well. Just to show you some more data here, the arrangement is the same. So x-axis is again the time in the trial, and now we have on the left-hand side the heart rate in the y-axis, and on the left-hand side, on the right-hand side, the physical activity. And just having a look at this data shows us that the heart rate drops with the initial fluid administration before chemotherapy, and then during the trial the heart rate starts to rise. This may be driven due to cardiotoxic effects, or also of course due to some effects that may occur due to complications, and then the heart rate increases. I think what is on the right-hand side, the fact that the activity bars or the activity plots really diverge here is a nice way of showing how different the behavior from an inpatient cohort is to an outpatient cohort. So usually if I have a normal audience, not an online audience, I always show this data and say we have longitudinal data and high resolution data. So make a guess, what do we do with it? This shows a few or select the vital signs of the wearable. We have heart rate on the upper left-hand side. We have oxygen saturation. We have activity on the bottom, on the left-hand side, respiration rate, upper right, temperature, which is the surface temperature, and on the bottom right is a quotient of heart rate and activity. And I always say, like, is this a normal day, or is this a day where we have to be, concerned about our patient? And as you can see, this is more or less showing a regular day defined by, the clinical data we found. So the visit entries, the laboratory results, and also the vital signs obtained on the ward. So guess again, is this a day where we need to, be concerned about the patient? And of course, I needed to show you as well some more concerning data here. And you can see that the heart rate of this patient remains above this 100 beats per minute bar here which may be an indicator, that here is something concerning going on. But the problem for analyzing this data is there's just too much. So we have a huge amount of data. We have gaps in there, which is actually, those gaps are driven by the fact that the wearable had to be recharged every 24 hours. And we said to all the patients, please recharge the device during your morning hygiene. And we have artifacts here. So we have here on the middle right-hand bar, plot the temperature, and you see this spike going up where the temperature rises above 40 and then drops again. And we have a lot of noise in this data as well. So I think the most important point of the learning we had is there is a medical need for actionable information. So I think none of you has time to review all this data to then come up with a treatment idea or handling those patients. So the need for actionable information is really there. And I will conclude my presentation just after this slide, but we came up with an idea to extract those actionable information. We're still a little bit, just a short time, hopefully, before publishing those data, and came up with a self-supervised contrastive learning, which is an approach from the artificial intelligence area, which enables, or which has two very good benefits for this big amount of data. So the first thing is that we can do raw data processing. So nobody has to review the data before entering or giving this data to the artificial intelligence. And the other thing is that due to the fact that the complications are very heterogeneous, that's what I showed you before with the 140 SECs occurring during the trial, the algorithm just has to learn what is different from what we would call or what we would consider normal. So this is kind of the advantage here for the unsupervised learning. So thank you very much. And really looking forward for some questions.
Thank you very much, Malte, for sharing another beautiful experience. And it is actually quite impressive, the amount of data that one can generate. Okay, so let's start now the discussion, and I have already a lot of questions to you, so I'll throw some of them, but of course, Alberto, you can also lead this discussion with our guest. So we have a first question, because I think this is for you, Alberto. You mentioned this in your talk. What is a digital stethoscope?
A digital stethoscope is a stethoscope which can translate into a digital sign the type of data is receiving from the outside, which in the case of a stethoscope are frequencies and vibration, basically. But this vibration can be translated into digital data, and then digital data could be sent to the distant side, then transformed again or interpreted by softwares. So the doctor from the distant side can listen to the sound of the stethoscope. Actually, I think that in that case, it was a Littmann stethoscope. You can check. And so that's basically a stethoscope, which is quite expensive, but it has this ability which could transform analogical data to digital data. Is actually what we are doing. If we are using listening to vinyl music, that's a standard stethoscope with analogic data, and you're passing through Spotify, that's digital, and you can send this data wherever you want.
Excellent, thank you very much. There is another question, maybe Jonas, you can start, and the colleagues can comment. What is the role of the family or caregivers in this process of remote monitoring, at least in your experience?
That's a great question. I think they have a very important role, especially in the acute setting when patients can decompensate quickly. We actually want the patients to have a caregiver to be in the outpatient setting for anything that could happen unexpected. I mean, I think having a family member or a caregiver there is kind of having an insurance, right? We are still learning about the remote monitoring. We're still learning how we're going to use the data, and I don't think it's a perfect solution anyway. So we actually ask patients to have a caregiver with them to be in the outpatient setting. If they don't have, then they're hospitalized, but they do have a very important role.
Okay. Any comments from you, Alberto or Malte, about this issue?
I would totally agree. I think for the most important part here is the safety of the patient. And as long as we are still in this phase where this is all, more or less research, and we don't really know how to use this data and have the safety margins to be very sure that we don't miss any complications which needs to be treated. I think it's very important that the patients have, caregivers at home that could take care in case of any emergency, or just call the ambulance, for example, if someone is passing out or something.
Yeah. Also,
sorry, John. I think that it's extremely important still today to select patient. At least this is our current experience. You have a patient, especially a younger patient, with that can use digital mobiles, for example, without any problem, where the telemedicine system actually performs perfectly. And then you have other patient, older patient, or without digital education, where the system is a complete failure. And this is so, it's very difficult. I think the selection of the patient, it is still fundamental in this field.
So here you're bringing another issue, and we have a question about this, Alberto, and it's it can be directed to all three of you. Is the impact of the age of the patient on the feasibility, but also let's call success or efficacy of this kind of telemedicine or remote monitoring? Did you see any specific impact of age? Is this something dedicated to the young, or actually we do have some good experience with the elderly patient? Because in hematology, our malignant hematology, our median patient age is between 65 and 70. And that's not always the generation which is the most highly connected, I would say.
May I? It's very interesting because we thought in two trials now. So the one was the Comet Class trial, and a different trial is one in a heart failure population. And at the end, it seems to be that age is not the critical determinant for being adherent to such a program. It seems to be more like is to use a tool to use it instead of just the age. Because we, at the beginning, as we started, it was the same in the heart failure population like in the oncology population. We thought that, well, all these young patients, they will uptake it right away and there will be no issues. But we thought that even some of the young stopped using the system. So at the end, the dropouts were more or less the same age, were from all age areas.
Yeah. I agree with Malte. I don't think it's necessarily the age, it's more the kind of the comfort level using some of this technology. We have several patients in our RPM program that are above the age of 75 or 80. The median age was, I think, just in the low 60s. So I think some patients are more familiar than others. I don't know how much the age is a factor, more than just the familiarity with using the smartphones and things like that.
Yeah, that I think that is the problem of the digital education, which in fact is another point which should be stressed. when using newer technologies. And also I think that it is strictly depending on the type of the technology, because the system that you use at Mayo Clinic and at Malte in his clinical trial are, I mean, looks like they are completely autonomous. I mean, the data are transferred completely in an automatic way. We didn't have such a clinical trial. Also, we are currently using wearable devices, but they are relying also with interaction with a mobile app. So I think that technology could eventually win against this digital barrier if we are automatizing all these systems. But the point is that we don't know, or we still don't have an official or a system which is better than the other one. So it's quite difficult for me to select which wearable devices should we use. Most of these wearable devices have no clinical approval, so it is a problem for us to use them in your clinical practice or in clinical trials. And I'm kind of lost, I mean, within all this technological world, and it's quite fast. So I'm not an engineer. I mean, I think that having a good engineer team also, it could help in this setting. Otherwise, you get lost because it's so big, this world.
Excellent. Thank you very much. One question to you, Malte, is how do you handle, because you generate a lot of data. I mean, I was quite impressed with one of your slides. So how do you handle the additional, I would say, unexpected information or even abnormalities that you would discover that otherwise would have been simply missed, you know, because I believe we don't monitor our pulse every minute and do whatever. Did you encounter this, and how did you handle this?
So as I try to show in the data, it's really, you know, tough to use such an amount of data. So we don't really use, you know, every heartbeat or every single data point of this wearable. I think our focus is more on really trying to provide actionable information. So we were just, you know, feeding the AI with all data available, and then trying to find out if the AI is able to detect the clinically documented complications. So it is a retrospective analysis, of course, because it's kind of the first step. But what we are seeing is we're really good with this high resolution longitudinal data to detect those complications. And I can tell you as well, we're also able to predict those compared to clinical documentation very well.
Okay, wonderful. So now my question to all of you, because we've been talking about telemedicine to monitor patients. But then there is another aspect, and I think, Alberto, you alluded to this in your introduction, which is telemedicine, I would say, between doctors. For instance, we are now, it's almost 8 p.m. In Paris, and assuming I have a CT scan or a blood smear and I need interpretation, and for some reason, no one is available on site to do it. So how can we also use all of these technologies to broaden the expertise, and because not every single hospital is going to have a radiologist on duty 24 hours a day, etc. Is there any experience in this, and how did it work?
I can take the first stab at that. I think that's a very good point. I mean, we have learned with COVID, you know, we're all using Zoom or Microsoft Teams or whatever other platform. Communication is much easier these days than it used to be in the past. We have not used this technology for kind of a, let's say, physician-to-physician consultation or questions from different hospitals or institutions. I think one of the biggest barriers we have faced here with that was patient privacy or HIPAA, or our HIPAA laws, that would be very difficult for us to be able to share that directly with a different physician, potentially sharing some private or patient information. Just the legal component of that can be a barrier, at least in the US.
So I think mean, this is kind of where the idea came from with the wearables, is to support such, telemonitoring or teleconsultations with objective data, because my colleagues from hematology always said that it's very difficult to interpret, if you just receive a call and saying, hey, I don't know, I have this and that, and you don't have any objective data on the patient. So I think really this is something where the wearables can help to monitor those patients. And I think also that between doctors, this may be of benefit to tell the specialized care center, maybe this patient needs special attention, because we do see in the data that it's really deteriorating and the patient is feeling worse or something. So this also, I mean, it might be a contributive factor or contributive aspect here.
Okay.
I agree with both of you, but I think that we are just beginning to discover such technologies, and so I think that right now maybe you'd like also to add not just vital signs monitoring, but also biochemical monitoring. I mean, that could be the next step. Glucose, electrolytes. I'd love to check hemograms of the patient, by telemedicine, and maybe in the future also the last step, which will be the therapy. I mean, domiciliary therapy, but I think that we are talking about the future. But it is true that if you're looking at how the big tech companies are approaching telemedicine, actually they have a lot of interest into this, Amazon or Google. And so I'm expecting in the next year that we will live a revolution, maybe driven by private companies before, and then also to the public healthcare system.
I don't think the future is too far away, Alberto. I think treatment at home is not something that's too far out.
Well, I think that technology is faster than biology, and so you can see that, and it's very impressively rapid. So maybe, I don't know, maybe next year, who knows? I mean, I cannot provide it, but if you look at the curves of how technology is improving, and you compare to biology that in oncology is improving as well so fast, but technology is faster, and that's great for all of us.
Mm-hmm.
Well, Alberto, one question to you, and this is from a colleague who was following very carefully your slides, because on one of your slides you said that, for instance, patients who were in clinical trials were excluded from whatever telemedicine follow-up. But then one may wonder that, I mean, we have faced the issue, myeloma patient receiving maintenance therapy with lenalidomide, and because they are in a trial, they have to come every month just for a regular checkup, whereas this can be easily done by telemedicine. So what's your feeling about this? Is there any something specific? Because we know that in hematology, clinical trials are really the backbone for advances, but we know that they are a big burden on the patient, in terms of follow-up.
Yeah, I think that, the colleagues is referring to the study by the Italian group, where they see that a patient who were on clinical trial was hardest for them to transfer the visit into telemedicine. In that case, it was not specified the type of clinical trials, but I think that it was related to the fact that you are required from the protocol that the visit should be in person. Well, I think that also the pharmas should probably change their vision, but I think that maybe a good telemedicine visit could be helpful for the patient, avoiding waiting list, wait time for the visit. And if this is not necessary, to make this in person, it could be accepted. It doesn't mean that telemedicine is inferior, but it is true that you can apply that to just very specific categories of patient. And also, I think that in general, the structures of clinical trials, it's something old school. So maybe also in this setting, clinical trials should be reviewed, and maybe we should start changing and applying newer technologies in our daily life, not just during the COVID pandemic. And now we are free of the COVID, so we are to go back to the old school. No, just let's learn from what we have learned from the COVID, not just forget about it.
Jonas?
No, I completely agree with Alberto. I don't think we're too far away from that perspective. I think some companies are already kind of looking to the decentralized trials or remote trials to facilitate access to patients. It's so difficult sometimes for patients to travel far away for a clinical trial. And some trials, I think they are more prone to that option, especially the oral treatments, that to bring that to the patient instead of the patient coming to us.
Okay. Any last thoughts from the panelists? Well, I think this discussion reminded me of a famous quote by Einstein, saying that I never think of the future, it comes soon enough. And it looks like that in the field of telemedicine and remote patient remote monitoring, this is really moving rapidly. Once again, thank you all for really sharing this beautiful experience. Very innovative, very unusual topic, but I think we need to get ready to face the future. And as you all mentioned and highlighted, technology is moving really very fast. And that is exactly the spirit of everything we do. At the ICH, we always love to be ahead of the game, on the forefront of development. So thank you all. I wish you, wherever you are, a good day, a good night, a good afternoon, or even good sleep, and hope to see you soon at another ICH activity. Thank you, guys.
Thank you.
Thank you.